and prepared a case for us as well. So we're all set and ready to go if we want to get started, Joy. Just gotta wait for the board to pull up here.
Okay. So we have for us today a female in their 60s who presented with about 2 weeks of lower extremity numbness. So do you want to talk about that, or do you want me to give you more?
I think we have the whole hour, so let's
Okay.
kind of grind it out as much as possible. But I'll have Andrew take a stab at it first and see what he thinks.
Yeah, I will be authentic here and say off the bat, this is not something I encounter very much in internal medicine, like isolated numbness of the lower extremities. It's definitely a rare thing we see in internal medicine. So I'm gonna have to kind of come up with an approach on the spot for this right now. I guess we could do it anatomically though. Just thinking of like decreased sensation, like paresthesias, like is there something happening in the spinal cord that could be causing bilateral extremity numbness? But that had to be like in the sensation realm, like the temperature pathway. But then you can go further down and talk about the nerves, basically there being like bilateral peripheral neuropathy causing lower extremity numbness. And then, characterizing this a little bit further, like, is this patchy or is this truly symmetric bilateral? Because it's more patchy. I'm thinking of what is it called, multineuritis multiplex, something like that, mononeuritis multiplex. Then we would be thinking of things like vasculitis. So I think probably what would be most helpful for me to come up with a differential for this would actually be to get more information maybe on kind of the true anatomy of this. Like, is it truly symmetric? Is it patchy? History in terms of past medical, if this is a patient with diabetes, it suddenly can become very easy because they could just have peripheral neuropathy from their diabetes. So yeah, I think the anatomy, the WHO, and concurrent symptoms along with this would be really helpful for me to kind of go further.
Absolutely great approach. I actually I have a schema for lower extremity, maybe edema. We had a case of lower extremity edema about lower extremity pain, but numbness in itself, system one thinking I would jump to, like what Andrew had mentioned, must be a neurological problem. But what I would like to see also is there associated weakness with this complaint? Is there also any changes that may hinge towards possibly a vascular decompensation or compromise? So you can have either arterial, which can cause paresthesia. So paresthesia is close to numbness, maybe. You can have an acute arterial emergency of the lower extremity, but then I would want to see some skin changes, temperature changes, and also weakness accompanying that as well. Venous changes, you may want to see an increase in probably the girth of the lower extremity, so edema, as 2 weeks of this process, something in the vein or something causing obstruction outside or compromise of the vein would cause extravasation of fluid. So there would be other accompanying changes, but just having pure numbness has me thinking towards what Andrew had stated, a neurological process. Then also you have to start thinking about who is the patient. So 60 years of age, does the patient, like Andrew had mentioned, have diabetes? Probably a very common cause of neuropathy that we may see. Is there anything in the social history like alcohol use? Although with alcoholism, patients do tend to have a hypersensitive sensation, I guess, something like maybe feeling of burning in the lower extremities, rather than having numbness. So at this point, I really don't know. I'm sort of moving in all directions and have yet to catch anything that I can focus my attention in on. But those are a few things that sort of cross my mind, along with what Andrew had mentioned. So back to you, Joy.
Wow, so really great thoughts. So she said that there has this numbness and tingling in her feet. Started about like 2.5 weeks ago, and she had this before, like years ago. which she attributed to her some of her chronic illness. We can talk more about that later. So she didn't think too much of this at the time, but like over a week or so, from presentation, she noted that this numbness and tingling now is have progressed to her knees. And by the time she presented, it has reached to her mid thighs. Also noticed that in about 24 hours, she noticed difficulty buttoning her shirt and using the remote control. So do you want to talk about that, or I'll give you the ROS, or what you or
yeah, I think we can go into the ROS and then stop there, because there's something evolving here. It's very interesting. I think we can, Andrew, we can explore this further. But yeah, go into the ROS.
Okay, so additional information here from the husband. So the husband noted that she actually had difficulty. She noticed that she had difficulty rising from a seated position. She kind of pushed up from a chair, and took her a little longer to stand. And her voice was noticeably changed to, like, she has hoarseness in her voice, like 2 days prior to presentation, but no dysphagia, no difficulty swallowing, no change to her eating habits, nothing like that. No changes in her vision, no imbalance, no recent trauma, no what do you call it, difficulty breathing or something like that, or shortness of breath, and yeah, no orthostasis. So but she did disclose that she had a diarrheal illness, like around 6 weeks ago prior to presentation. She had a low-grade fever, but it spontaneously went away like in 24 hours. So she did not think anything about it. So do you have more questions?
Yeah, I think, Andrew, what do you think before I jump in?
Oh yeah, I think that's plenty of information to dissect right now. That's extremely helpful. So I think translating some of this information, this sounds very much, I'm translating all this into like a very rapid polyneuropathy. I think because it started distally, it's ascending. And then interestingly, along with that, there's some mixed signs of like proximal and maybe even distal muscle weakness too, like having a difficulty getting out of a chair is a classic sign of proximal weakness. The whole like messing around with the remote sounds more distal to me. So it sounds like proximal plus or minus distal weakness concomitant with rapid decreased sensation in both the feet and the hands. And I think that's the other thing. I don't recall if the hands started after the feet, but that would be classic too, and that the feet started first and then it went up and then the hands were affected. If I recall, that's kind of the usual order for peripheral neuropathy. So suddenly now it's like this, you know how before I didn't know how to approach the numbness, now I can very easily approach this as, okay, like polyneuropathy. And if you don't mind, I'll take one out of Robbie's book and actually share the screen of just my approach to polyneuropathy, being authentic. I, again, don't see this very much in internal medicine, but Dr. Mansour has this framework for polyneuropathy, and you can stratify it into axonal mediated versus demyelinating processes in these buckets here. You can ignore kind of like what that means for a second, but there are metabolic causes of polyneuropathy. So I was talking about diabetes earlier. You can also consider hypothyroid, nutritional deficiencies like B12. There's toxic stuff. We already kind of talked about this with maybe does she drink alcohol, but these are like very chronic things so far. So we'll use the acuity in a second to kind of stratify. And there's inflammatory causes with infectious and non-infectious being stratified further, and then hereditary stuff. So basically there's like a first pass and a second pass workup for doing this, but I think what'll be most helpful is going to time course. So I also have this stratified by time course. So for acute neuropathies, Ravi actually already mentioned ischemia and you can consider like compartment syndrome, but you have to consider this patient isn't really having like a local focal like syndrome. This is really like true peripheral neuropathy, it sounds like. I would think that polyarteritis nodosa and RA would also be kind of like patchy, like the multineuritis, multiplex, mononeuritis. I can't say that. So this sounds maybe like it could be relapsing remitting, since she's had maybe some episodes in the past, but I don't know, because she also had this diarrhea recently, and I think that's on everyone's minds in terms of like preceding diarrhea before neuropathy. So definitely we're going to be thinking of AIDP here. And then porphyria, we don't really have a signal for other stuff like abdominal pain. And yeah, I'll just leave it at that. You can clearly go very deep into this. There are like a lot of etiologies, but I think the acuity is probably what's on most of our minds right now in terms of investigating this, because this is very, very rapid.
Yeah, I don't think I could have broken it down as well as Andrew did, but that schema is extremely powerful. It just incorporates everything we sort of had thrown out there: metabolic, infectious, toxic. But you know what? What's very interesting is the association of this prodromal event, right, Andrew? This something happened just before this, about 6 weeks ago, and I think it's still within the time frame, although I would like to see it a lot sooner associated with the sequence of events here. But sort of system one, step one thinking would be something that was right up there, an acute inflammatory demyelinating polyneuropathy, GBS. So this a sequential ascending sort of a neuropathy that would signal to us possibly GBS. But you know what? I don't want to just put everything into one basket, but I also want to explore all the different domains here. So this association does make me think in first glance of this process, but what else could there be? I think Joy had mentioned initially something musculoskeletal, but this is diffuse. This is happening in many different locations, from the lower extremity to the now we involving the upper extremities, and also the hoarseness of voice. So this is a multi-system, I don't know yet, inflammatory, assuming we connect the dots to the infection and a process. So it would have to be one of those that Andrew had mapped out in that fabulous schema by Andre Mansour. But I yet don't know where the answer lies. But at this step, if anybody had to guess what would be the further workup with this kind of weakness, maybe EMG, nerve conduction studies, some imaging of the brain to make sure it's not something in the brain, or is it in the spinal cord? And also we may have to get a sample of CSF to see if there's an answer there of possible inflammation. But anything else, Andrew, that comes to mind before we send the mic back to Joy?
No, that all sounds great.
Okay, Joy, back to you.
Okay, so relevant past medical history here. She had focal segmental glomerulonephritis, and she had a renal transplant a year and a half ago for that. And she's having infusion of CTLA4. I can't say the brand name because I don't know how to say it. I can't say it properly. So it's a CTLA4 immunosuppressant, because she can't tolerate the side effects of tacrolimus and the other one, mycophenolate. So, and she has hyperlipidemia. She's taking statin for it, and she has hypothyroid. She's on Centroid also. So yeah, that's for the past medical history. And then the next aliquot would be the neuro exam or the physical exam.
I guess we could stop right there. What is very interesting is the hypothyroidism. And as Andrew had mentioned, initially the complaint suggested this proximal muscle weakness. Well, hypothyroidism can manifest with proximal muscle weakness, just like statin-induced myopathy can manifest with that. If I'm thinking right, steroid-induced and several other conditions, associated conditions, could manifest with proximal muscle weakness. But here, that definitely is something that stands out to me. And I'm very interested to see if the patient is taking their thyroxine properly or taking it not with meals. Occasionally, we have patients that refuse to take their medications or ran out of their medications. So this is of great interest to me to see if this is the cause of this presentation. And especially hoarseness of voice can be manifested or can occur due to hypothyroidism. What do you think, Andrew?
Yeah, I agree with all of that. When I saw the statin too, I also thought for a second, you know, because they do have the weakness. But in terms of neuropathy and an event related to taking statin, I'm not so sure if that's related. I'm pretty sure that's not in the illness script, but it was on my mind for a second, like, oh, immune-mediated necrotizing myopathy from statin and the weakness. But I don't think that this neuropathy sounds consistent with that. And then, yeah, in terms of the CTLA-4, I don't know what's like an immune related adverse event would look like for that, but I feel like those things do everything. I don't know if this kind of very, very symmetric distal presentation would fit with that, but it's certainly possible, I think, given how many events can happen with those drugs.
Yeah, absolutely. I've sort of reached the limit of my knowledge with this CTLA-4 infusion, but something to look for. But then what I see in parentheses is immunosuppression. So could this hasten the occurrence of an infectious process? And we do have this signal of diarrheal illness 6 weeks ago. The patient is immunocompromised potentially from this infusion. So something we have to think about. But let's go to some more information and see where we can narrow our focus in on. Joy, back to you.
Okay, so I think Andrew should move to neurology. I mean, he's picking up amazing to me. He's picking up everything so well. I mean, if the whatever it is that he's doing right now doesn't work out.
Joy,
Yes, very good.
just being authentic, Joy. Again, this is something where I would be looking at my
Yeah, that's why I'm
all the
amazed.
time. I've had to look at it this whole time. This is one of those things I never see it, and I've done so much reading because it's very confusing.
You're picking up the physical exam and the salient findings. So yeah, moving on to physical exam. So so her vitals were normal, 99% saturation, room air, and temperature is 98.1, and heart rate 82, respiratory rate 16, and BP is 101 over 66. And the medical sign-off was completely normal, other than they noticed the hoarseness was documented. So mental status, normal, really normal. And cranial nerves were also normal. The uvula midline, the palate raised equally, no tongue fasciculations or weakness or atrophy, and the eye muscles, the EOMs, were within normal limits. Motor, tone, and bulk were intact, and no pronator drift. And so direct confrontational testing, there was diffuse weakness and asymmetric. So the right upper extremities were 4 out of 5, but the left was 5 out of 5. The hip, the right hip flexors were 3 out of 5, while the left was 4 out of 5. The knee flexors and extensors on the right was 4, while on the left was 4 plus. So it's a little bit more on the right. The plantar flexion and dorsiflexion were 4 bilaterally. Like no ptosis, double vision, or on prolonged up gaze, and no fatigability in shoulder abduction bilaterally. Sensation intact throughout bilaterally, other than there was some mild vibratory sense impairment on the toes. Light touch were intact, mostly tingling, not loss of sensation. And coordination was intact, like the finger to nose and heel to shin were intact. Gait, she had difficulty rising from seated position to standing, but when she started ambulating, her gait was normal, but cannot do tandem, given the lower extremity weakness. And so the reflexes, so +1 upper extremity reflexes, no Achilles reflexes bilaterally. She did have like a bilateral knee replacement. Maybe it could be that, or maybe not. And so just to clarify further, like looking for sensory level, like a myelopathy signal, there was none, and no percussion tenderness over the spine. So yeah, do you have any more clarifying question about that, PE?
Go ahead, Andrew.
Oh yeah. It's funny for me to dissect here. I think it's always helpful kind of translating findings, because Joy clearly did a very thorough exam here and is testing for very specific things. And a lot of times this is written in the chart, but it's not always clear kind of why things were performed. So just some things that stand out to me. Difficulty rising from seated kind of confirms our suspicion perhaps for proximal muscle weakness. In terms of like the slight asymmetry, this reminds me of a lot of cases we talked about recently where perhaps this is a symmetric process where one side just kind of begins weaker before the other side, because there is some subtle weakness, it seems like, on the left side. And if she's really having a hard time getting up from seated, then it makes me think that that left leg weakness contribution is probably real. So in terms of like, it's not perfectly symmetric, I think this is probably going to be something where it's going to be symmetric, but it just hasn't progressed to that point yet where both sides are fully affected. But we won't fully say that yet, but that's just kind of what's on my mind. And the no Achilles reflexes bilaterally, I think is suggestive of a lower motor neuron localization, which a peripheral neuropathy falls within that like anatomy tract. So that kind of confirms our thought as well. The no percussion tenderness over the spine, I think what we're looking for here is like, is there like cancer or osteomyelitis in the back that's kind of causing cord compression? I don't think that's going on, because again, the upper arms are affected too. But that was done to, I believe, look for like a CNS, physical CNS lesion that would be causing cord compression. Those are my initial thoughts. Ravi, what about you?
Yeah, very good breakdown of the exam. So the hoarseness again bothers me. I'm sort of stuck on this hypothyroidism again, and it can manifest in many different ways. If you think back, I think it was last Thursday or before that, my medical student Amelia presented a patient with myasthenia crisis, so not myxedema coma. So there were some points that patient, I think, mainly had altered mental status, but this diastolic elevation of blood pressure, bradycardia, and then this proximal muscle weakness would manifest with that too. Although the Achilles reflex bilateral, like Andrew had mentioned, this could point towards a lower motor neuron issue. So namely things to look at if there's flaccidity, no Babinski in the patient's neurological exam. So yeah, at this point, I'm not quite sure. Bilateral knee replacement, was there something to do with that? I'm not quite sure if that could also cause an impairment in obtaining that reflex. Is there foot? So if there's no Achilles reflex, with hypothyroidism, you would get that Waltman sign, delayed relaxation, when you do elicit the Achilles reflex. So that would be something to look for, which I'm not also seeing here. But somebody mentioned, Neeraja mentions in the chat, slowing of reflexes, Waltman sign, dryness of skin, puffiness of face, cold intolerance. So there's like a multitude of different manifestations that the patient can have. But at this point, difficulties, if I just try and hone in, this repeated difficulty trying to rise up from a seated position, that does indicate a proximal muscle issue. So going back to the initial schema that Andrew had deployed, you have certain things, infections like you had mentioned. So HIV comes to mind, that can manifest with something like that. Drugs we had mentioned. So again, the patient not taking the thyroid medication, if they're on steroids, the statins, obviously something that are high up in a differential, but then again, this numbness doesn't quite correlate with that. And then you can have other endocrinopathies that could manifest with that. Just you may have hypercalcemia, hyperparathyroidism. And then you have these this constellation of muscular issues called muscular dystrophies that I can't recall all of them, but you have, I think on neuro VMR, we do talk about things like Becker, limb girdle, and there's, I think, one more, and another thing to think about, myasthenia gravis. So I can't help but think Joy is perpetuating neuro VMR on Tuesday VMRs when Andrew isn't here. I mean, when we're not having neuro VMR, but we're probably going to have to cover some of the bases, Andrew, for neuro VMR in trying to tackle this case. Any other thoughts, Andrew, before we move on to the next article?
Just you bringing up the neuromuscular etiologies, the one translation I forgot is the no blurry vision and the no, what was the other thing? There's no blurry vision and like no nystagmus. I forget if that was written down. Those are signs of fatigability of the eyes that you can see in neuromuscular etiologies too. Just something to keep in mind. Maybe that decreases the chance that this is a neuromuscular.
Right. So great point. Like, so for myasthenia gravis, you do have a certain number of features. Also with like the Miller-Fisher variant of Guillain-Barré, you may have ophthalmoplegia. So in missing the eyes here, but this still could be something maybe along the lines, you have this diarrheal illness and you have this progressive weakness. So again, AIDP, CIDP, are we in the domain of GBS? I don't know, but maybe the answer lies in some CSF. What do you think, Andrew?
I feel like that's where we're going. I hope we get a lot of data though. This is really interesting.
Okay, back to you, Joy.
So given this, as part of the physical exam here, given that the ascending paralysis that's going on here, so we did assess their diaphragm there. So the best thing to do that is to have the patient. She was able to count 45 with just one breath. So it was, because like in this case, you cannot see, at least initially, the saturation would be normal and the AA gradient would look normal because this is not a lung problem, but a muscle diaphragm problem. So yeah, so that was okay. That was normal. So like as far as the workup, which one would you want first for as far as like imaging, LP, which one would you guys want first?
I feel like if I had to pick one thing, just with the whole problem representation, it would probably be the LP. But Ravi, do you agree with that? If we had to pick one thing,
I think so. But Andrew, let's approach it like you mentioned, the real world. How does the sequence of events play out?
So in real world, I think a huge shotgun of tests would be sent, kind of thinking of epidemiology. Again, a lot of those things don't follow a time course here, but I think in the real world at my hospital, they would probably send all of these studies. So just going back to my notes here, that would be things like an A1C, a TSH to check the hypothyroid, LFTs, vitamin studies, And then also things like gammopathy workups like SPEP, serum immunofixation, HIV testing, and Lyme. Those would be the first ones. The second pass things like autoimmune screening, I'm not sure if we need that quite yet. Paraneoplastic panel, I'm not sure if we need that quite yet. I feel like what should be in the first tier, given her presentation at the diary, is probably the LP. And also, I think what would be gotten is a nerve conduction study.
Yeah, I think rather than just pick one, it's usually in the real world imaging, LP, and all those studies sort of would be obtained simultaneously. And I like that you did a phenomenal job, by the way, Andrew, from your memory. You just were able to bring out those tests so fluently and eloquently. And I like that you put in there HIV. What we didn't, having to step back and look at, somebody had mentioned, Moataz had mentioned about the past medical history and this FSGS. Now, that can manifest due to HIV. I'm sure they must have done during the workup of renal disease, HIV, but that's something to think about. And it can always be missed in the workup. So very important to at least get that test as well. Back to you, Joy.
So just to, I like the thought of that you guys are thinking of something infectious here. So yeah, that's really good. So I'll give you first the, okay, so you can talk about the LP. Just to like what I learned from this, is in this case though, like whenever there is the chance of a myelopathy, such as in this case, like a immune compromised patient, elderly, so think of infection, think of malignancy that could be compressing the cord. So you would do first imaging here and like rule out anything cord before doing an LP, because like if there's if you pull out a pressure there, if there's like a partial compression, you could translate it, convert it to a full compression. So that would be a disastrous for your patient, like full complete cord compression. I mean, so the LP here was the results were there was 3 nucleated cells and 80% lymphocytes. Those were 80% lymphocytes, and a protein of 66.2, glucose 56, and also did the serum glucose at the same time, which was 90. So thoughts about the LP result?
I'm Googling albuminocytologic dissociation to figure out what qualifies for that.
So yeah, while you look that up and see, but here, nucleated cells and 80% lymphocytes. So we have pleocytosis, the glucose that's normal, protein is elevated. Is that right, Joy?
Protein is 66.2.
Is that elevated? I don't know.
Not really within the normal.
Okay.
A little bit like borderline, but still within the normal for this patient. But then you could also attribute that to something chronic, right? Like a diabetes.
Yeah, this.
You have to think about also that they're immune suppressed, right? They're getting CTLA4, which is a really powerful immune suppressor. So they might not be able to mount a good immunity reaction.
So this paper, it says normal CSF usually has a total nucleated cell count less than 5. So I think this person does not have elevated cells in the CSF. And then the total protein, they actually give 2 different values, it looks like, based off where you draw the sample from, but the higher number is 45 mg per deciliter. I don't know what units we're dealing with. Do you happen to have the units, Joy, on the protein?
I do. I don't have. So it changes though, depending on the laboratory. So I don't have the units. Sorry.
Okay. Yeah, I'm not. Yeah, according to this paper, that protein would be elevated and may qualify as like the dissociation, but I don't know enough about this topic to say that with confidence.
So, Dr. Singh, you would.
Yeah, I don't think it really moves the needle for me. I mean, the 3 nucleated cells, thanks Andrew for putting that in for clarifying that. So 80% of the cells are lymphocytes. So, lymphocytes, if there's a predominance of lymphocytes, that it would indicate viral phenomena, glucose normal, but protein should be elevated. But then again, the CSF won't follow the textbook. There are certain conditions which can cause signature, like the albinocytologic finding with Guillain-Barré. You can get pleocytosis and elevated protein, say syphilis, neurosyphilis, but here I'm not. I mean, it'd be something a part of that very nice panel of tests that Andrew had mentioned, but right now it doesn't really speak much to me. But not cloudy like you mentioned, Joy, so not overly aseptic picture. But I think we would have to move on to imaging and the other laboratory testing, as well as the EMG nerve conduction testing. Oh, I just want to also mention, if the opening pressure was elevated, that could also signal to us, like you mentioned, immunocompromised patients or cryptococcal meningitis could also be in the differential if we're thinking about it. But I'm not getting a sense that the patient is having headaches or other intracranial symptoms.
None. Okay, so she had an MRI total spine with contrast study. So the results were normal. Though there was a few mild degenerative changes, like multi-level, but no significant central canal stenosis, nothing that is impinging the cord. So the cord is totally fine. So yeah, do you want more? Do you have any clarifying?
Maybe just like the initial labs, like the lab screenings.
Oh, yeah, so what was the course, the plan, given the LP and the imaging and the fact that they're getting the CTLA4? So they obviously the presentation, the clinical presentation of the patient, which was ascending polyneuropathy, acute to subacute. So she was being clinically treated as GBS. So she was given the so this was a clinic. She was clinically treated as GBS, and she was treated for CTLA4, at least the phase 4, the monitoring surveillance. They did find that there was 10% association with GBS for CTLA4. And so she was given the standard course of IVIG, which was like a 0.4 per kilograms per day for 5 days. And her symptoms slowly remit. So resolved after 24 hours. Her strength continued to improve by the time she finished the course. All her strength extremities were, in all muscle groups, were +4. And so, but there was this, so she received pre-transplant CMV status were negative, but then she received a transplanted which was a positive CMV, the kidney that she received. So yeah, and then the following day they did went looking for that. The quantitative for the viral load for CMV was very high, like 5 log, and there was like 2 million copies of CMV. And so she was also started with foscarnet around the same time that she was started with IVIG. And the thought was also maybe not withhold the CTLA-4 infusion, at least the next round. But then given that high viral load for CMV, the transplant docs were really, really pretty sure that this was CMV, you know, because she cannot receive the other the therapy, which she has a really bad, she cannot tolerate them. So yeah, as far as like the confirmation here, like the nerve studies were done because this was during COVID. They were trying to limit exposure. Yeah, so it wasn't done. And so yeah, that was that. It's CMV, possibly more likely the CMV GBS. But then there was like also, this was not a typical response for after IVIG, maybe because like she resolved like almost dramatically immediately after receiving IVIG. That doesn't happen with the classic, at least the classic GBS. It takes some time. It does, the IVIG just stop the demyelination, or if it's the axonal type, at least stops the process, but then it allows the body to heal. But it doesn't. It's not like this. But yeah, that was what was happening here. So maybe it was like they caught it early. Like the process wasn't that bad. So yet.
This sounds case reportable. I think regardless of the endpoint diagnosis, I think my biggest takeaway from the case is there's a pretty limited differential for acute polyneuropathy, which is really what this person had. And like going back to my list here, just with how diffuse it was, I think AIDP or Guillain-Barré syndrome just like had to be at the top of the list given how short it is and given the treatment required. So I think the acuity was really helpful, regardless of the final etiology. And yeah, Ravi, other thoughts? Very hard case.
Oh yeah, Andrew, it was very fun. It was fun. I was very happy to have you by my side in the trenches, trying to decipher this case, because I agree it was extremely difficult. Because I mean, we kind of had that great schema, but there was just so much involved in that schema. And what could you use from this case to sort of decipher or bring out focus to at least one branch point of that schema? But it very much did feel, I think, in the beginning we had GPS as a course, but you couldn't help but think about all the different buckets and that associated diarrheal illness. But fascinating, we touched upon the thyroid, we touched upon immunocompromised status. We didn't really touch upon, we did look back at the kidney, but this transplant. But I think what I will take away, possibly this diarrheal illness causes, maybe we have two dynamic processes occurring together. You have this CMV, then you also have this diarrheal illness causing this GBS. So can two things occur in simultaneously together? They could have. Maybe we always get this patient coming in with one thing and then having an underlying secondary process, which wouldn't have been picked up if they didn't come in with the primary cause. Just like I had a patient come in with ACS and actually had a malignancy, which was found during the workup. So are they related? Probably not, but I would go back and then just think about transplant organs and the associated infections, and namely the ones that come to mind. CMV does travel with transplanted organs, especially the kidney. VZV can also travel with the kidney. BK virus can also travel with the kidney, not to mention all the immunosuppressive medications, PJP, and then you have bacterial infections that occur. They usually don't occur immediately. They may occur maybe a month to about 6 months out, usually with transplanted organs. So kind of peculiar. This was 1.5 months ago, and this patient suddenly had just a surge in this CMV. And I didn't really get a sense of CMV from experiential learning. CMV, if I've seen it, the patient is very toxic, which this patient was. Patient tends to have high fevers, weakness, maybe have diarrhea, maybe also have some elevation in the liver enzymes as well. But in this case, I wasn't seeing that. But then again, this is a very different presentation of CMV. So very interesting case. It definitely has my head spinning. I'll be thinking about it the whole day. So Joy, you've tested my neurological sort of brain again. So I'm definitely improving neurologically, and look forward to you bringing many more cases like this again.
Andrew got it like halfway. He was thinking already CTLA4 when I mentioned it. So really good instinct there. I have to say.
What I've learned about immune-related adverse events after recently publishing a case report on it is they're so unpredictable. They could really do anything. So that's another takeaway for sure.
Okay. Teaching points with a combination of Maddie and Deborah.
Yes, we will kind of in combination do these teaching points, but really, really blown away by your discussion, Robbie and Andrew. You totally were just, so honest about what you knew and didn't know, and just walked through it in a really, really fantastic way. And thank you, Joy, for the case. So we started with the chief concern of lower extremity numbness. And one approach we took was an anatomic approach. So we thought, is this a pathology at the spinal cord level or at the nerves? We talked about the additional history you want when someone presents with lower extremity numbness. So is this, what is the pattern of the numbness? Is it patchy, which would make you think of a mononeuritis multiplex? Is it truly symmetric? You want to think of who the patient is, which could, especially in this case, inform the differential. So what is the immune status? Do they have a history of diabetes or alcohol use, which can on their own cause numbness and paresthesias? And then also other information like associated weakness, changes in the vascular system, skin changes, etc. When we got a little bit more information, we were able to frame this patient as polyneuropathy with associated both distal and proximal muscle weakness. And Andrew walked us through a really great framework for this, which is kind of the buckets of disease. So is this a metabolic process like diabetes or hypothyroid? Is this toxic like alcohol? Or is this inflammatory? And you can think of both infectious causes like HIV and Lyme, and then non-infectious, including autoimmune processes like Guillain-Barré. And then lastly, hereditary. And then you can use the time course and the presence of preceding events to filter these differentials, and ultimately kind of the acute aspect of the presentation, the prodromal diarrheal illness, were important clues here. And I'll pass the mic to Deborah to finish off with the second half of the teaching points.
Thank you. It was a really great discussion. Yes, we went for the past medical history, and then Ravi asked if it could be the hypothyroidism that could cause this weakness. The patient could be the hoarseness and present to slowing of reflex and a dryness skin. And we ask if the patient have been taking the medication, or if it could be a staging that induced the myopathy. And the physical exam, we think about the proximal muscle weakness, maybe a symmetric process, or if it could be an asymmetric. We said no ankylosing reflex. It could be a cord compression indicated a CNS lesion. We can look for Babinski in lower motor dysfunction, and for blurred vision in Guillain-Barré and myasthenia gravis. And going for the labs and everything, Andrew will teach us that in this case he will do a first pass with A1C, TSH, vitamin studies, HIV and Lyme disease, and then in the second pass he would go for heavy metals, autoimmune, and paraneoplastic. Then we think about that the GBS, usually we can see albuminal cytology association, elevated protein in normal cells on the lobar function. And we thought about in the lobar function if the elevated opening pressure could be in an immunocompromised patient, cryptococcal meningitis. So yeah, great discussion. Thank you so much, Ravi and Andrew and Joy, for this case.
Thank you.
Thank you, Madeline, Deborah. Great teaching points. Lots of fascinating points there to mull over. Thank you, everybody. Thanks, Andrew, for co-discussing the very challenging case, but it always makes us stronger. So take care, everybody. Thanks for coming on. Have a great day.